Day 2014 was the largest ever voluntary collective action for improvement in the history of the NHS, with more than 700,000 pledges made to take action to improve experience and outcomes for patients. Helen is acknowledged globally for her expertise in large-scale change and ability to translate it into practical action and deliver outcomes. So I'll hand it off to you, Helen.
Yeah, oh, that's great. So thank you so much. What a lovely introduction. And it's wonderful, you know, that I can join you in this way when we are you know, so far apart. But I think philosophically, in terms of, you know, what we're trying to do, I think we're very close. So can I just do a sound check to start with? Can everybody hear me okay? Yeah? Yeah, great. So the title of my presentation is Rocking the Boat and Staying in It, How to Be a Great Change Agent. And you know, I've worked in health and care improvement, quality and safety for a very long time, and worked with lots of change programs, some of which have been great and some of which haven't been great. And I think that, you know, so much of this is about who we are and how we operate in the world, and our ability to lead change. And I think that anybody that is a champion of quality and safety, you know, has to rock the boat, because in a sense what we're doing is we're looking at the status quo, we're understanding the things that stop people having great experiences of care, or the things that lead to poor outcomes. And if we're going to be the people that challenge that, we've got to be the boat rockers. But you know, sometimes there's a lot of dangers with being a boat rocker, so we also need to be able to stay in it. So I hope that you'll find this talk stimulating. So let's start off by from like my perspective. So I'm trying to move the slide, and it doesn't want to. So I can't advance the. Yeah, can you advance it for me? Aha, great. So you know, this picture here comes from an art installation from an artist called Adam Katz. And what he did, he took 12,000 of those, do you know those little tiny orange plastic soldiers? And he stuck them on a window. And it said, all of my good ideas are battles. That's the words that he spelled out. And I know exactly how he feels, because, you know, when I look back over my whole career, being a change agent, every single thing that I've been part of that's been a positive thing has been a battle. Often it's been a battle to get engagement or to get funding. Sometimes it's a battle because people resist change or say no. And I wanted to complement this with this quote from the evolutionary biologist Thomas Huxley. And here he was talking about Darwin and his theory of evolution. And he basically said, new truths begin as heresies. And I believe that. You know, I believe every new truth starts as a heresy, because the people that have got a vested interest in the status quo and the way things are at the moment don't want to hear new truths. So what I'd like to do now is show you a new truth that that I think that many of our leaders or people that lead our systems don't believe yet, but I think it's very pertinent. So if I could have the next slide. This comes from Gary Hamel, and Gary Hamel is based in New York. And according to the Financial Times of England, he is the most influential business leader in the world. And his new truth is that change always starts at the fringe or at the edge, and it always starts with the activists. And, you know, I work in a very big system. So the English National Health Service, we provide care to 54 million people, and we employ 1.4 million people in our health and care system. It's the biggest health system in the world. So, you know, loads and loads of change going on, and often the people at the top of our system, you know, the most senior leaders, like we think that change starts at the top, and we think that power trickles down. But the actual reality is very different. You know, change starts in a different place. It starts at the edges, and it starts with the people that are the activists. So I think we need to actually create more of our change on that basis, rather than trying to create very big system-wide change programs. Or maybe we need to do both. And I think this is even more important given the direction of change. And my job, I'm Chief Transformation Officer with the National Health Service in England. So what I do is I connect up all over the world with people who are the futurists, the leading edge practitioners, the researchers, you know, the people that are thinking about the next phase of change. And what's interesting is that whatever sector we look at or industry, people are saying the same things about change. So what I would like to do now is a whistle-stop tour through the changing direction of change. So if I could have the next slide. The first thing is that where change happens. So I'm calling these seismic shifts because they are very, very big changes that are happening in the world of change. So globally, across every industry, change is becoming more disruptive, and it's happening, you know, more and more quickly. So you know, we're not just talking about small-scale incremental changes anymore. We're talking about very, very big changes. So if I could have the next slide. The second big change that we see happening is the revolution that is created by digital connection. You know, all of us can connect with virtually anybody in the developed world 24 hours a day, 7 days a week, with very little cost or effort. You know, the fact that I'm talking to you now from Coventry in the middle of England, you know, I think is part of that. So, you know, the difference that is making around our ability to connect with each other and to get knowledge, you know, with each other is making very, very big differences. So if I could have the next slide. The third change that is happening is that the nature of work is becoming more and more complex. And that's happening in every industry. It's certainly happening in our industry in terms of health and care. And certainly here in England, if you were to talk to, you know, a doctor in a hospital in England, what they would say is that, like every doctor would say, compared to 3 or 4 years ago, the people that we are caring for in a hospital environment are much thicker overall. If we talk to colleagues who work in primary care or community care, they'll say the same. You know, people who even 4 or 5 years ago were being managed under the care of hospital specialists, we're supporting them fully now in a primary care setting. So as work becomes more complex, there's one very specific consequence of that. And if I could have the next slide. That is that the power of hierarchy is diminishing. So in the past, you know, we work in organisations and we work in systems. The people at the top of the hierarchy could pull a lever and people in the system would kind of do different things. But it just doesn't work in the same way because, you know, as a result of change happening more and more quickly, the way that we're connecting, and it means that we can't just contain work in neat little silos of organisations anymore, and that hierarchy just isn't working. So whilst we need to work through the system, it isn't enough. And if I could have the next slide. The final big shift that's happening, again, globally. Can you see me? Hear me?
I can hear you.
You can hear me. Can you see the pictures?
Yes.
Yeah, okay, great. I can't see you at the moment, but that doesn't matter. If I could have the next slide. Is it there? Can you see a picture that says, in the middle, change from the edge? Okay. Yeah, that one, yeah, that's great. What's happening is that change, research and development, innovation is moving to the edges of organisations. Okay, and again, looking at this globally, you know, if we look at the big manufacturing corporations, you look at pharma, that the research and development functions that used to be right in the middle at the heart of organisations are being moved right out to the edges of organisations. And the reason that this is happening is very clear, which is that if we're moving in a world where we need to innovate more disruptively, we need to move more quickly, then we need to have a change functions, research and development, innovation, where people have got one foot in our organisation and one foot outside. So we're constantly bringing in new ideas and absorbing them into our organisations. And exactly the same thing is happening in healthcare in terms of where we need to put our innovation, our improvement, our quality ideas. So, you know, we're living in a world where change is just happening so quickly. I mean, if you look back even 10 years ago, you know, we didn't have Skype, we didn't have Facebook, we didn't have Twitter, we didn't have the cloud, we didn't have 3G. You know, our world has changed so much. And yet when you look at the ways that we go about change in our organisations and systems, and you look about the way that we manage performance, by and large, our world has changed, but the way that we deliver change hasn't changed at all. So there is a very, very big kind of disconnect between the way that we're doing change and the reality of our changing world. So if I could have the next slide. So there are lots of people who influence me, and this is one particular piece of research that's influenced me quite a lot. And this was an article that appeared in the July and August edition of Harvard Business Review 2013. And it was written by two Canadian researchers, Batalana and Casciaro. And they went into a very big organisational system, and they followed 68 change initiatives around this very big system. And they worked out who were the people that could actually make change happen, you know, who were the people who you know, could truly lead change. And does anybody know what the name was of this very big organisational system that these two Canadian researchers went round? Does anybody know? Has anybody seen this? We're quiet. I'll tell you. It was the English National Health Service. So these two Canadian researchers followed 68 change initiatives around the English NHS. And it's a very interesting article. And what I'll do is I'll leave you a set of these slides. And at the end of these slides are two slides that are just packed with different references that I've utilised during this talk. And you can click on this article. But the two things that I find most interesting for our conversation today, the first thing they found was that being an effective change agent, you know, being somebody who is able to lever change and lead change is very little to do with my position formally, like where I fit in the hierarchy. It's very little to do with whether I'm the most senior leader in the organisation or I'm somebody that works at the front line of care. It's much, much more about my position with regard to networks. So it's about, you know, where I fit with regard to network. And if I'm in the middle of an informal network, it's much easier for me to lead change and I'm more likely to be effective than if I'm a senior leader in the hierarchy. The second thing that Batalana and Casciaro found was that if we want to create small-scale incremental change, which is good, you know, we want small-scale incremental change, you work through a cohesive network. And what we mean by a cohesive network is being in a network with people like me. So emergency room doctor with emergency room doctor, family physician with family physician, community nurse with community nurse. You know, I'm in a cohesive network. It's peer-to-peer influence, and that's great for small-scale change. But if I want to create really big change around the system, then what they said we have to do is that we have to create bridge networks between groups that are disconnected. And what they mean by that is, you know, people are in their coherent networks with people like me, and if I want big change to happen, I've got to join up the different networks and get people connecting together. And, you know, certainly in our system in England, very often we have ambitions for very big change, but the way that we're going about it is peer-to-peer through cohesive networks, and there's a disconnect between our ambition for change and the way that we're going about it, which is likely to lead to underachievement. Just to have the next slide, another piece of research that I think is really interesting. This comes from Leandro Herrero, and he's worked out a process for putting a quantitative value on influence. And what he's found is, again, people that are highly connected, that are in the middle of the network, have got twice as much power to influence change as people with positional power. And, you know, what that's telling us is that, you know, the kind of leaders that we want to be, and if we want change to happen in our organisations, again, if I could have the next slide. You know, we need to be convincing people less through, you know, I'm the clinical leader and of this clinical division, and I've got some key performance indicators for you, and much more, again, if I can have the next slide. I have a dream. You know, that if we're going to be the kind of influencing leaders of the future, we need to start with I have a dream. And you know what? If we start with I have a dream, then, and people get that and understand the why, it's much, much easier to do key performance indicators. So let's go back, you know, to this issue about how our world is changing, and the need, you know, to move very, very quickly in change. If I could have the next slide. We're moving to a world of very big ongoing change, and disruption has to be the new normal. You know, and often we're saying, oh, you know, I'm in my team, you know, we've got change fatigue, we're burnt out, you know, can't we have a little intermission for change just for a while, just to get our act together? And the reality of our world is that disruption is going to just be a way of life, more and more and more. So this is a quote here from Celine Schillinger, and what she says is that actually in this world that we're evolving towards, the people that actually can create the most value in organisations are the people that are doing the disrupting. You know, the people that are questioning the existing ideas, the people that are saying, you know, here's some new things that we can do, and questioning the status quo. These are the kind of people, the kind of change agents that will actually help our organisations survive and adapt moving forward. So it's great to do this, to say, you know, we need to be the disruptive change agents of the future. But what's our reality? Again, if I could have the next slide. What happens to people in organisations who are heretics, disruptive innovators, radicals, rebels and mavericks? You know, do they have a nice life? And the reality is, you know, that where we're the kind of people often who are challenging in this way, if I can have the next slide, we end up being the kind of people that get burnt at the stake for questioning, for being disruptive, you know, for not conforming. And there are so many pressures on us to, you know, to behave, to conform with everybody else. If I could have the next slide. And you know, this is interesting. So this is about neurological research, and what it's showing is that ostracism, you know, being socially isolated from our peers, can be experienced in the brain as deeply as physical pain. There are so many factors on us that are kind of pushing us to conform, to not speak up, you know, when we see bad things happening, to not rock the boat, you know, to not challenge the status quo. And yet, in terms of, you know, the direction we're going in, the need to change, what our patients need, what our communities need, we need to be rebels. So if I can have the next slide. So what do we mean by rebels? So we mean, you know, the people that are the principal champions, the leaders of initiatives for change, for causes or for action. And the thing about rebels is that they don't wait for permission to lead. You know, they don't ask, they get on with it, they innovate, they strategize. But they're not like unguided missile systems, you know, causing havoc around the place. They're responsible people. They do what they do because it's the right thing to do. And rebels are incredibly useful people in organisations or systems because they name things that other people don't yet see. They point to new horizons and new possibilities. And I think this is my favourite quote about rebels. You know, without rebels, the storyline never changes. And yet our patients, our community members, our service users, they need the storyline to change. So we need to have rebels. So if I could have the next slide. In order to be rebels, we need to be boat rockers. We need to be the people that can rock the boat and challenge the status quo, but manage to stay in it. And as boat rockers, we're the people that can walk the very fine line between being different and fitting in. You know, we talked earlier about change moving to the edge. We need to be the people at the edge that have got like one foot inside the organisation, but another foot outside, bringing lots of ideas and connections into our organisations and systems. And boat rockers are the people that can challenge the status quo, challenge the way that we do things, that, too often mean bad experiences for people that use our services or unsafe care. And, they're the people that are able to challenge, not stay silent. And if you look at the research about people that are very good boat rockers, what it shows us is that these people have got the ability to both conform and rebel at the same time. And certainly, that's my experience, that, I work in a team that's full of very radical people wanting to do transformational change. But what we know is that we have to be the best conformists in our organisation. So we're the people that always get our performance reports in on time. We're the people that always turn up for meetings. We're the people that never, ever talk badly of anybody else in the organisation, because we know that if we want to do the radical, rebellious, transformational things, we have to be the best corporate citizens going. So I really identify with this issue about conformance and rebellion. And the key thing about being an effective boat rocker is that we're capable of working with other people to create success, okay? We're not disruptive troublemakers. And I want to show you a framework now, if I could have the next slide, that really helps me to think about this in this context. So I think it's very helpful to think about the difference between being a rebel and being a troublemaker. So let's start off by talking about being a rebel. So rebels are people that create a different future. They are passionate about the mission, the patient or the person-centered mission of the organisation. They're optimistic about the future, and they generate energy in people around them and attract other people to them. In a situation, they will see all sorts of possibilities, potential and hope. And they're capable of working collaboratively with other people to create a different future. Okay, that's very different to being a troublemaker. A troublemaker is somebody who complains a lot, and the focus of the complaint is me, the injustice of my situation, how badly I've been treated. And troublemakers are often very angry about their own situation, and they've seen these change and improvement initiatives 100 times before, and they haven't worked, so they're pessimistic. And they sap the energy of people around them because they're so pessimistic and they're so angry, and they alienate other people. So when the positive rebel skips along and suggests a new way of doing change, the troublemaker will see 100 reasons why it's problematic. And as a result, they're often left alone. So just to say a couple of things about rebels and troublemakers. The first is that when you're a rebel in an organisation or system, very often other people will see you as a troublemaker, and it's really unfair, but that's what often happens. And the other thing I'd say is that I know so many people with clinical backgrounds, nurses, doctors, therapists, who go into clinical life with a calling, with a sense of wanting to serve, but find themselves in very difficult scenarios that are very toxic or dysfunctional, and they cross that slippery slope and become troublemakers. So what I want to do, I just want to stop there for a minute, and because you've been doing a lot of listening, just to give you like a couple of minutes to talk to people around you. So what do you think about rebels and troublemakers? Which are you? And just maybe something else you want to talk about is, what is it that moves people from being a rebel down that slippery slope to being a troublemaker? And how do we stop people from falling out of the boat? So I'll just stop there, just give you a couple of minutes to have your own conversation with the people around you, you know? Rebels and troublemakers, over to you. Hi, I'm sorry I can't hear your conversations, but there seems to be a lot of energy, which is great. So I think, yeah, lots of rebels and troublemakers in the room. So just one question I wanted to ask you is, looking at this list of characteristics of rebels, okay, there's one of those characteristics that is the most important when it comes to somebody being able to be a rebel and remain a rebel. Which one, can you kind of shout out so I can hear, or try? Which of those characteristics do you think is most important when it comes to being able to stay a rebel?
Optimist.
Yeah. Oh, I can hear lots of different ones, and that's great. Can we just go on 2 slides, and I'll show you the answer. Yeah. Together. Do you know one thing? However, like, creative, passionate, optimistic we are, in the environments that we work in, you know, the #1 rule of being a rebel is you can't be a rebel on your own. You know, we have to connect with other people. So, you know, let's carry on with this idea of being an effective change agent. You know, a boat rocker and a rebel. So I could have the next slide. This is another quote. This is another Huxley, but it's a different one. It's about 100 years on from Thomas Huxley, and it's old as Huxley. And he says, there's only one corner of the universe that you can be certain of improving, and that's your own self. And, you know, very often we're like a clinical leader of change, and we can look at a situation and we can say so many things need to change. So just thinking of some of the work I've been involved in, for instance, dementia-friendly hospitals, say, in England. You know, I get put in charge of a project in my hospital to create a dementia-friendly hospital. And I can go in and I can analyse, and there's so many things that need to change, you know. The process by which we admit people as emergencies, okay, you know, we're not doing an early enough assessment as to whether somebody's living with dementia, you know. So we need to change the process there. Then when it comes to actually admitting somebody into the hospital and putting them onto a pathway, well, the nurses need to change what they're doing because it isn't working. And how we work with the drugs, the medications for people living with dementia, well, the pharmacists need to change what they're doing. And then how we get people back home again, well, the social workers need to change what they're doing. And it's very easy to look at a situation and say, well, all these other people have to change and all these other processes have to change. And actually, they're outside of our control, because the only thing that we can control, really, is ourselves. So change has to start with me. So if I could have the next slide. So what do we know in terms of change starting with me about successful boat rockers? And the evidence base suggests 4 things. And again, you'll see some recurring themes here. The first thing that we know about successful boat rockers is that they are able to join forces with other people to create action. Again, the #1 rule of being a rebel is you can't be a rebel on your own. The second thing is about just being able to create small wins. And sometimes, we underestimate how important it is to just create small changes that give us a sense of hope and possibility as confidence. The third aspect is how we think about things that get in the way, how we think about barriers and obstacles, and seeing them as challenges that we can overcome, which is connected to #4. And again, if we look at the literature base around people that are really good organisational change, effective organisational change efforts, this issue of self-efficacy is really important. And what we mean by self-efficacy is the extent to which I believe in the context of this change that I can actually lead the change. Because if I don't think I can do this, if I get told, we want you to lead this change project, and I don't believe I can do it, then the reality is that I won't. So if we could have the next slide, let's look at self-efficacy 101. Okay, so let's start in the top right-hand corner. The guy who's the sort of guru of self-efficacy thinking is Albert Bandura from Stanford. And he says the ability to act is tied to a belief that it's possible to do so. So the extent to which we truly believe that we can lead this change and deliver it, okay, will have a very big impact on whether we achieve our outcomes. And Henry Ford, the motor guy, he understood this 100 years ago. He said, if you think you can or you think you can't, you're right. Okay, and again, the modern day evidence backs that up, and I just have a little statement here. There is a positive, significant relationship between the self-efficacy beliefs of a change agent and his or her ability to facilitate change and get good outcomes. So a lot of my work in the NHS in England, working with staff at the front line of care, is about actually developing our own self-efficacy as change agents. And if I could have the next slide. This picture, this cartoon, it comes from a learning review that we commissioned about 18 months ago. And we worked with hundreds of people at the front line of care. And the biggest issue that came back was our colleagues saying to us, I don't believe that I have got permission, I don't believe I've got permission to be able to create even a small change in my service. I don't have the permission to be able to make the change happen. And I don't know if that's an issue in your system, but it's the biggest issue in our system, with regard to change. And so when we start to think about self-efficacy, I think it gives us a lens on this situation. If I could have the next slide. So what's really going on here? Is this an issue of permission, externally generated, i.e., the culture within which I'm working is so risk averse that I just don't have permission? Or actually, is the situation that's going on here one of self-efficacy, whereby actually it's how I feel about the change? And I think in our system, too often we treat it as a permission issue when actually self-efficacy is at least part of the dimension that's, what's going on here. And the good news about this is that we can work with people that are change agents and we can build our own self-efficacy. So if I could have the next slide, here are 5 tactics from the evidence base for building our own self-efficacy as change agents. And again, look at this, it's the same basic principles that you know, we keep seeing in the rebel and boat rocker literature, okay? You know, number one is about creating change one small step at a time, you know, to give ourselves confidence. The second is about reframing our thinking. Too often, certainly in our system, we don't want failure, you know, we mustn't fail. But instead, why can't we reframe this and say, actually, this is a learning opportunity. Sometimes when we're like the clinical leader, you know, the senior leader, we have to show that we know the answers. So when people are asking us to answers to questions, you know, we've got to know. But instead, why don't we say, well, I'm not certain, but I'm really curious as the answer. Okay. Number three, make change routine rather than exceptional activity. So how can we build in improvement, you know, cycles of change into everything that we do? Okay. Number four, get social support. Again, the number one rule of being a rebel is you can't be a rebel on your own. And number five is learn from the best. So if we're working on a particular project or program area or with a particular group from our community or group of patients, who are the best people in the world at this? You know, and very often actually we come to Alaska and we come to you because actually we think that in terms of a lot of the things that we're trying to do with the NHS, with integrated care and new models of care, that actually we learn greatly from you. But you know, who are the best that you can learn from? So what I want to do finally in my talk is to illustrate this issue about reframing our thinking. So if I could have the next slide. You know, often when we're trying to make change happen in our services or within our communities, there are so many reasons why people say no. You know, our lives as change agents are often about constant rejection, constant battles. And somebody will say, well, we tried that in the radiology department in 1978 and it didn't work. Or it's not in the business plan. Or we haven't got the money. Or the senior leadership team will never accept that. You know, very often it's kind of no, no, no. So if we're going to be challengers of the status quo and, you know, constantly pushing forward, we need to reframe our thinking about no. Just before I want to take you into showing you the reframing, I actually want to show you my really favourite one from the NHS. So if I could have the next slide. So what this says, you know, yes, this idea is really innovative. Unfortunately, we can't consider it as it's never been done before. So yeah, another no. So how might we think differently about all these no's? If I could have the next slide. So I'm a really big fan of an approach that's called go for no. So instead of saying, well, I don't want to be socially humiliated or I don't want psychologically to have to deal with rejection, let's increase it, okay? Let's go for no. Let's get lots of no's. So if I could have the next slide. Because the thing is, you see, about having a no is it's not personal. So when somebody rejects my great idea for improvement, they're not saying, you know, well, we're rejecting you as a person. Actually, they're rejecting the idea. So let's go for no. If I could have the next slide. And, you know, when people say no, let's respond positively. Let's try and understand, you know, why are they saying no? What can we do about it, you know? How can it be a learning opportunity? Let's have number 4. You know, how can we do it differently next time? How can we value the no? In fact, if I could have number 5, why don't we make no a personal performance target? So, you know, I'm going to go for 5 no's this week or 6 no's this week. And because, again, if I can have the next slide, see, the thing about no doesn't mean never. And just because somebody's saying no now doesn't mean that they'll always say no. So, you know, so we get this now. You know, I can be a go for no woman or a go for no man. So the next time you have your you know, great change project and somebody's going to reject it, then, you know, great, go for no, be positive, okay, value it, learn from it. And like we might say, well, you know, that's ridiculous. But actually, we can take some really good learning from other sectors that show us that go for no might not be such a bad idea. So the first piece of evidence I want to show you on the next slide is from the sales industry. And again, when we're trying to influence people to change, often it's like we're trying to sell our idea. And what this particular piece of evidence shows us is that in the sales industry, only 2% of sales are made on the first contact. So the first time I try and sell something to somebody, there's a 98% chance that they'll say no. And actually, if you go down towards the bottom of the slide, 80% of sales are made on the 5th to 12th contact. And actually, I think as change agents, it's probably a similar ratio. So, you know, when I'm trying to get my ideas across, let's get through, number 4 to 11 asks really quickly, so that we can actually get to a stage where we're going to get a yes. Okay. And the other piece of evidence I want to show you, if I could have the next slide, comes from the field of scientific research. And what this is about is that very often, you know, scientists that are really creating breakthrough change, they obviously want to get their new ideas into good journals, into peer-reviewed journals. But what happens is, because their ideas are their science is very new, the people that often are peer-reviewing their work are the people that are the bastions of the status quo, who've got a vested interest in the way things are. So these scientists that are coming up with, you know, these really great new ideas are very, very likely to get their studies rejected from publication. So what these researchers here did was looked at things over time. And what they found was that those researchers who got their research rejected to start with were often the ones that were most influential later on when it came to the number of citations, you know. So in a sense, these leading edge research scientists, they've had to learn to go for no as well. So coming to the end of my little talk now, so just a couple of more things I wanted to say. If I could have the next slide. What we're trying to do, you know, globally, is to build a movement of change leaders in health and care who are working with these new ideas and new ways of going about change. So one of the things that I wanted to maybe suggest is that we have a virtual hub for change activists in health and care. And people from all over the world connect with us and give us ideas around the links that we should be looking at, writing us commentaries. So it's really worth having a look at that. And then just a final slide. Some of the ways to connect with us and this bigger community of transformationally minded leaders in health and care. So to follow us on Twitter, as I said, to subscribe to The Edge. And we have a school, a global school for people in health and care who want to rock the boat and stay in it. And all the materials are freely downloaded. So a little bit of, you know, what I've shown you today is a little bit of that. But again, all those materials are available. So yeah, I hope you like those ideas. I hope they stimulated, inspired you a little bit. And yeah, really happy to take any questions and answers if there's time.
Everyone's just overwhelmed.
We're very quiet. I know. Should I be worried?
No, I think it's good. They're thinking. Oh, here's a question. Dr. Engel, pediatric intensivist.
Yeah, I was just, I enjoyed your talk, and I was wondering if you could give us a specific example of a change to the system. We're talking very high, at a very high level.
Yeah.
Something specific that you've used this method to accomplish.
Yeah, of course. So I'll use the example around people with living with dementia and antipsychotic drugs. And this has been like a really big problem in our system for a very long time. We identified that there were, our analysis showed that there was something like 110,000 people in our system living with dementia who were being given antipsychotic drugs inappropriately. And that, you know, I mean, I don't need to tell you the impact on their lives, but very often it was devastating. So, you know, so the idea was, how can we, you know, put right this terrible situation? And very often we have a very big system. So what we would, you know, what would often happen is that the people at the top of our system would say, these are the new prescribing guidelines for clinicians. and doctors and the pharmacists that support them need to adhere to these guidelines. And we might add in a few sticks and carrots, you know, that if you're not adhering to these guidelines, there'll be a punishment, or if you are adhering to these guidelines, there would be some sort of you know, motive. But in a sense, it wasn't happening. It wasn't happening across our whole system. You know, people with dementia were continuing to be prescribed these drugs, and you know, very often when people living with dementia were given these drugs to start with, it was appropriate, but often only for a very short time. But what happened was that these drugs, you know, just kept being prescribed. So we decided to use these methods of change, this way of thinking about change, to change the situation. So what we did was we said, you know, who are the people that we need to engage in change? Not just through the hierarchical system and compliance, but in terms of the change agents across the whole system. So we started to work with people living with dementia and their families, with the advocacy organisations, with the care homes that lots of people living with dementia live in, that are in the private sector, with the big pharmacy chains, with pharma, with the medical community, and the organisations that represent them. But we started from a place of commitment to say, you know, what is the goal that we all want, and what are the actions that each of us can take to make a difference, and who are the informal leaders who can make a difference, and not just working through the hierarchy, but actually working through the opinion leaders and calling people to action. And across our system, across the whole country, we've seen a 51% reduction in the use of antipsychotic drugs, and people are engaging in the change, not because they have to, because it's imposed on them, but because they want to, because it really matters. And I think that, you know, we live in a world where we have to work in both ways. You know, of course we have to have compliance for high quality, safe care, but increasingly we have to work with commitment and treating everybody as if they were a volunteer, as if they were getting involved in the change because they want to.
Okay. Dr. Frank.
Yeah, I'm curious, what do you see as some of the biggest things that you'd like to see change in the United States healthcare system?
Yeah. Okay. So some of the things that I'd like to see changed in my system, and again, I'm a change activist, so maybe I'll do it in two ways. The first is just how we go about change, because there's so much evidence around you know, effective change, and that if we work through commitment and we build shared purpose and we treat everybody as if they were a volunteer, and we treat every single person, whether they're you know, a clinician or a patient or a family member, as a leader of change. I'd like to see that change. I'd like to see much more thought, what I'd call thought diversity, lots and lots of different voices in change. So you know, in a sense, we have years and years of evidence and experience of change, and yet we keep making the same mistakes over and over again. And as our money is very, very tight in our system, as the money gets tighter, very often what our leaders want to do is to get even more control and manage risk and you know, and work through kind of compliance and conformance and cohesion. And I think it's the opposite of what we need to do. And then the other thing I would like to see, and it's happening in our system, but it's not happening you know, quickly enough, is the whole situation where you know, people are responsible for their own health. And I think, again, in terms of what you're doing in Alaska, I think it's such a role model, you know, for us around you know, how health and spirit and social care come together, how people are more, you know, take responsibility for their own health, the kind of partnerships that exist between communities and the and the clinical system, and people take more responsibility, and we integrate the care. So I think what you do on a relatively small scale is kind of what I dream of for a population of 54 million.
Any questions?
Can I just make one comment?
Sure.
Yeah, sure.
I just want to say I'm English and I've worked in the NHS for 13 years and I was there last week doing locum, and I'm incredibly proud of the NHS. I think it's fantastic, but the pressures are absolutely utterly overwhelming, and particularly the social care. And I know they thought I was a complete pain last week because I kept on saying, this is your problem, you go and deal with it, I can't do anything. So thank you.
Thank you.
Yeah. No, I mean, the pressures in our system, I mean, absolutely agree, are incredible. And in a sense, it's why we need to do things in different ways, I mean, we need to build on all the amazing strengths that we have as a system. And like you, I'm really proud to be part of a system that, from when we're born to when we die, we get healthcare that's free at the time that we need it, regardless of ability to pay. In a sense, what we've got a responsibility for is to make sure that, like my generation, that the healthcare that we've taken for granted, that it's going to be available to the next generation and the generation after, which is why we need to think about change in different ways.
Thank you. Thank you so much, Helen. I really, really appreciate you being here. And admire you, and I wanted to live Twitter the event, but I'm not technologically efficient at that yet in my career. So I'm hoping I can get additional training from you another time for that.
Oh, wow. No, it's it's a pleasure, and I don't know how much, if you realise just how much the eyes of the world are upon you, and what you do and your philosophy. Is such a sense of hope and possibility to other people. So thank you that we can interact, and thank you for all the learning that you give us.
Thank you.
Okay, bye then.
Okay, yes. We have found Lisa, Margaret. She's my touchstone here. Okay. So I just had a few words. Thank you so much for being here. So I was going to give you just a brief update. We're almost done. Please enjoy more food. There's so much of it. But I've been assured that it will disappear after we're gone. So this is more of just a description of what the medical